Today we are going to master infantile Blount's disease, a very important topic for exams. By the end of this video, you'll clearly understand what it is, why it happens, how to diagnose it, how to differentiate it from physiological bowing, and complete management. Let's start. Infantile Blount's disease is a progressive pathological genu varum. It occurs due to a problem in the medial part of the proximal tibial growth plate. It usually affects children between 2 to 5 years of age. More common in boys. And about 50% cases are bilateral. Remember, this is not normal bowing. It is a progressive deformity coming from the medial proximal tibial physis. Why does it happen? Or pathophysiology. The cause is multifactorial, but the main mechanism is very simple. There is increased pressure on the medial side of proximal tibia, especially in obese children, early walkers, genetically susceptible children. Because of this pressure, the medial growth plate gets damaged. Growth slows on medial side. Lateral side continues growing normally. So what happens? The tibia bends toward the medial side, leading to progressive varus deformity. In severe cases, a physial bar or bony bridge forms. Remember this concept. If one side of growth plate stops growing, the bone bends toward that side. Langenskield classification. This is a radiological staging system with 6 stages. It helps us assess severity and prognosis of infantile Blount disease. Stage 1. There is mild medial metaphyseal irregularity and beaking. Very subtle. Can resemble physiological bowing. Stage 2. More prominent medial beaking and early sloping of medial epiphysis. Stage 1 and 2 are potentially reversible if treated early. Stage 3. There is increasing depression of medial tibial plateau. Stage 4. There is deepening of the medial plateau and beginning of physial disturbance. Stage 5. Clear physial bar formation starts. Stage 6. Permanent bony bridge and severe deformity. Remember, early stages like 1 and 2 are reversible. Late stages like 5 and 6 have permanent structural damage. How does the child present? On examination you will see bowed legs, internal tibial rotation, flexion deformity, often bilateral, lateral thrust while walking and leg length discrepancy. And remember, there's usually no pain, no swelling, no restriction of motion. X-ray findings. X-ray is extremely important. Always ensure patella is facing forward, because internal tibial torsion is common. Findings include varus centered at proximal tibia, medial metaphyseal beaking, posterior slope, sharp angular deformity, progressive asymmetry. Drennan angle is very important. Also called metaphyseal diaphyseal angle. It is the angle between line connecting metaphyseal beaks and line perpendicular to tibial shaft. Interpretation. If angle is more than 16 degrees, then there's 95% chance of progression. If angle is between 11 degrees to 16 degrees, then observe closely. If angle is less than 10 degrees, then there's 95% chance it will resolve naturally. How to differentiate from physiologic bowing. In physiologic bowing, bowing is symmetrical. There's a smooth curve, no metaphyseal beaking, and improves with time. While in Blount's, there's asymmetrical bowing. There's a sharp angular deformity, medial beaking present, and is progressive. Differential diagnosis. Other causes of pathological genu varum are rickets, osteogenesis imperfecta, multiple epiphyseal dysplasia, spondyloepiphyseal dysplasia, metaphyseal dysostosis, focal fibrocartilaginous defect, physial injury, and persistent physiologic varus. Always rule out metabolic causes like rickets. Treatment is very simple. Let's break it down. Treatment depends on age, stage, severity, and presence of physial bar. Non-operative treatment is brace, that is knee, ankle, foot orthosis. Indications are stage 1 or 2, age less than 3 years. Brace is for about 2 years. Improvement should start within 1 year. Non-operative treatment works better if it's unilateral. Poor results in obese patients and if it's bilateral. Operative treatment. First is proximal tibial valgus osteotomy, which corrects varus, flexion, and internal rotation. Indications are stage 1 and 2 if more than 3 years. Stage 3 to 6. Age equal or more than 4 years. Failed bracing. Progressive deformity. Or Drennan angle more than 20 degrees. Best results of operative treatment if done before age 4. Second is growth modulation, like tension band plate, used in selected growing children. Third is physial bar resection. If bony bridge is present, it need 4 or more than 4 years growth remaining. It is usually combined with osteotomy. Fourth is hemiplateau elevation. It is for severe medial depression and done with osteotomy. Complications: compartment syndrome after osteotomy. Prophylactic anterior compartment release recommended. Recurrence is common, especially if physial bar present, and may need hemiepiphysiotosis or bar resection. Prognosis: best results with early diagnosis, early bracing or early osteotomy. Some stage 2 and 4 can spontaneously correct. Late diagnosis means worse outcome. If this lecture helped you, like the video, share it with your ortho friends, and subscribe to Ortho Doc for more exam-focused orthopedics content. In the next video, we'll cover another high-yield topic.